Welcome to This Week in Hearing. My name is Amin Amlani. I'm joined today by Jeff Hydar, Chief Commercial Officer at Photonicare, and Dr. Seth Pransky, a pediatric ENT physician. Together, we will be discussing how Photonicare is providing better and simple-to-use diagnostic technologies to clinicians. Welcome, gentlemen.
Welcome. Thanks for having us.
It's my pleasure. So, Jeff, you're the Chief Commercial Officer. Can you tell us a little bit about yourself before we talk about your company?
Yeah, absolutely. So my name is Jeff Hydar, Chief Commercial Officer at Photonicare. I have been in the medical device space for over 20 years and bringing new technologies to market, both in the imaging space as well as in soft tissue implantables. Really love the idea of bringing something that's new and novel to the market where people can improve the care they're delivering, or providers can improve their care, but also are making a difference, right? It's not just a Me Too product. I really enjoy bringing new, true technologies that are novel to the marketplace.
Great. And then we also have Dr. Seth Pransky. Again, he's a pediatric ENT. Would you tell us a little bit about yourself, sir?
Be happy to. Good day, everyone. My name is Seth Pransky, and I am a pediatric otolaryngologist. I've been in practice here in San Diego for 36 years, and for 20 of those years, I was the chief of the Department of Pediatric ENT at the Rady Children's Hospital. And my career has been both as a clinician and as an educator. We have had a fellowship program here in San Diego since 1990. And we train both residents and of the ENT world and the pediatricians. And I also have been the director of the CME department for 17 years, educating the primary care physicians and allied health personnel for 17 years. And so it's a pleasure to be able to be part of this discussion regarding what I see as an incredible advancement in the ability to correctly diagnose and manage ear problems.
Wow. Well, we appreciate both of you gentlemen being here and talking about this. So, Jeff, let's start out by talking about Photonicare. Tell us a little bit about the company, when it was founded, where you're located, and those kinds of things, please.
Yeah, so Photonicare came out of the University of Illinois, Urbana-Champaign. Ryan Shelton, one of our co-founders, along with Steve Beaupart, we're in a lab working on optics and optical coherence tomography. Ryan Nolan had joined them, and the three of the gentlemen founded the company in 2015 out of the need of really was a parent need. Ryan Shelton's child had been going to the doctor with repeated ear infections, and he just thought this is really archaic, the way we're diagnosing this, a lot of guessing. And they developed the technology to be very objective, which is what OtoSight Middle Ear Scope is. And as I said, in 2015, we commercialized the company and really began to develop the product. Product received FDA clearance in beginning of 2020, and we really began to commercialize it then. And again, we're co-located between Champaign, Illinois, and Durham, North Carolina. Durham has a ton of knowledge base and a ton of talent in the world of optics and optical coherence tomography. And we've been commercializing the product since, as I said, 2020.
Wow. Okay. So you mentioned the OtoSight Middle Ear Scope. So can you tell us a little bit about that?
Yeah, for sure. So the OtoSight Middle Ear Scope is an imaging device that allows you to really assess what's going on in the middle ear. A lot of times with kids come in with ear complaints or ear infections, you have a doctor using something that's essentially a magnifying glass and a pen light that was developed over 150 years ago to look in the ear and kind of guess, is there fluid, is there not fluid, is this infected or not? And they're really doing their best to do this in a subjective manner. What OtoSight does is it uses optical coherence tomography to look through the tympanic membrane into that middle ear cavity. And that middle ear cavity is where the fluid is, if there's fluid present. So we're actually able to identify the presence or absence of that fluid, the turbidity of that fluid. And what's nice is we can do that even when there's earwax present in the ear. So we're giving very objective data in a form factor that's very similar to the common otoscope that you're used to using, just with a whole lot more specificity than you would have otherwise.
Okay. All right. So as I was looking at your website here, doing my homework for this webinar, this webcast, And you talk about a 90.6% accuracy compared to a 50% accuracy with a traditional otoscope. So you've got some clinical evidence here. Can you talk a little bit about that for us?
Of course. Yeah. So there's data published in 2001 by Kakaro et al. Out of Rochester, New York, that showed that clinicians were accurate about 50% of the time when diagnosing an ear infection. And this was done by showing them images, and then they had to make a clinical diagnosis based on the patient history and other material involved, or other information involved. We followed that study out using the technology within OtoSight to look at similar images, showing them a surface image of the eardrum along with a middle ear scan. And those combined, they showed about a 90.6% accuracy rate. And again, this was against all comers. So we had everything from fellowship trained pediatric ENTs to hospital administration, and they all were very equal in how they assessed and diagnosed if there was fluid or not in the ear. Now, the benefit to this is this technology can be used by anybody, right? It could be the MA in the office, could be the nurse, it could be the provider, but it was very objective. There was no art that had to be learned in how to use the technology and be able to correctly diagnose the presence or absence of fluid or the turbidity of that fluid.
Interesting. So I'm going to turn this over to Dr. Pransky here. So you had mentioned that you train fellows and you've got residents that are coming in, and traditionally we've used an otoscope to look in the middle ear. Can you talk a little bit about how well that particular instrument, the otoscope, has allowed you to look at middle ear, and how this new product could potentially change the way that healthcare is being delivered in people who have middle ear issues?
I think it's important to understand that ENT is a tech-heavy specialty, and we have seen magnificent changes in our ability to manage, diagnose, and treat a variety of diseases that involve the head and neck. And it was an interesting interaction that I had with the Photonicare co-founders when walking through the Academy meeting one year. I saw them, began a dialogue, was interested in what they were offering, and as I learned more about it, saw the OtoSight as a sea change in the ability to appropriately and accurately diagnose what's going on in the middle ear. For me, as a clinician, I've spent a lot of time having to discuss with patients what they may have been told, which may not have been accurate in terms of their ear problems. Of course, as an otolaryngologist, I have technology. I have a microscope. I have the ability to have binocular vision. I have all the things that we need within our specialty, which is not available to the vast majority of those that are looking at the ear. So an otoscope is small. The light may vary depending on whether the battery is running down or not. And it is, quite frankly, challenging, especially when dealing with wax that might be in the way with a struggling 18-month-old who is irritable or crying or doesn't like something going into their ear. And consequently, what Mike Picicaro showed back in 2001 is that diagnostic accuracy is limited with an otoscope. And I saw the OtoSight as a sea change in the ability to visualize the tympanic membrane, to record it, to be able to review it, to show parents what's going on, and to assess the middle ear for the presence or absence of fluid, which quite frankly can be rather challenging and takes years and years of clinical acumen to really get right. So this has been an amazing development for routine standard care. Ear infections are the most common cause for going to the pediatrician after going for vaccinations and standard things like rashes and routine pediatric care. It's an enormous number of patients that go there being diagnosed correctly or sometimes not correctly with an ear infection and being placed on antibiotics. Needed, maybe sometimes not needed.
That's very telling of the clinical efficiencies that new technologies are starting to bring in, as Jeff pointed out. And you brought up the point here that it's using this on an 18-month-old, but can this technology also be used on adults, or is it primarily only for children?
Of course, this is a wonderful tool for all patients. What you get with the instrument, the ability to visualize the eardrum, to see what's going on in the middle ear, to spend some time to review what you've seen. So you don't get just a snapshot, you get a recording that you can stop and look at and spend time trying to figure out, is it or is it not something that's wrong with the tympanic membrane or the middle ear, is a massive improvement. Furthermore, all patients, parents, the patients themselves, adults, love to see what's going on in their body. We know that in the ENT world because we use scopes all the time. We're passing scopes to look at different parts of the anatomy, and patients are more than just curious. They're fascinated by what's going on. And now they can understand with a little bit greater clarity why a particular type of intervention has been recommended, be it do nothing or intervene with antibiotics or a recommended surgery. So of course, this is excellent for children, for adolescents, for adults, for literally for everyone. And in all marketplaces. I mean, it can be done in an emergency department, in an urgent care, in the primary care's office. The audiologist will benefit from this as well. Patients are curious. They want to see. They're used to it from the technology that we have in all other fields to be able to see and then be able to make a more informed decision.
Wow. And I'm glad that you talked about the fact that, there's different medical entry points in which this technology is going to be used. So Jeff, can you talk a little bit about how this is potentially being used in hearing care versus, for example, the medical setting, a pediatric office or an ENT's office?
Yeah, so I'm going to open the door, but I'm going to let Dr. Pransky really put the exclamation point on the statement. So, a lot of times, kids aren't very communicative or able to convey what their hearing loss is because they don't know what hearing loss is. What's really nice about this is when you're looking at this, you now can get a baseline for that patient of what their eardrum looks like or what that is. But I think, Dr. Pransky, we've had this conversation before. When your kid has repeated fluid presence and you do a hearing test and they have a decibel hearing loss, right? Talk about how you've had that with some of your patients, if you don't mind.
Well, I think if we just back up a little bit and talk about the fact that when you're dealing with an ear and either an ear infection or hearing impairment, the assessment has to be comprehensive. So you get the physicians look at the ear and the patient goes to the audiologist for evaluation of what their hearing level is. And that in turn is a complex set of tasks to identify is there or is there not a hearing impairment. So you have the hearing test and you have a tympanogram. So a tympanogram done by both primary care physicians and certainly by audiologists is an adjuvant tool to help determine if there is or is not fluid in the ear or what the status of the tympanic membrane may be. But it's exactly that. It's in some cases a confirmatory evaluation. It is not a diagnostic evaluation. It cannot tell you whether the fluid is infected or not. It cannot tell you if there's a significant retraction area or a mass behind the ear versus fluid. Whereas with the OtoSight, you get a chance to really see the eardrum and assess what's going on behind the eardrum. So in that case, it is a far more diagnostic tool, taking a lot of the guesswork out of the recommended management. And again, you can show the parent or the individual what's going on and maybe explain why they have a hearing loss.
Yeah, so it sounds like this particular instrument is a great differentiator in the marketplace. So Jeff, can you talk a little bit about that?
Yeah, so my mind right away goes to the whole continuum of care from the entry point of a patient into the care system to ending up, at someone like Dr. Pransky's office or any other, subspecialist. So, one thing we have with like a broken bone, for example, we have a common language. We take an X-ray, that X-ray goes into the EMR, and no matter who looks at that, you have a pretty good idea that there's a broken bone. There is visual proof of that. With an ear infection, we hear this very consistently that, you could back up to the entry point of the care system. The pediatrician never trusts the urgent care provider. The ENT doesn't trust the pediatrician. No one knows that anybody is doing the job properly. Well, with OtoSight, you get that scan, it goes into the medical record, And everybody who's asked that can clearly see the presence or absence of the fluid in the ear. They can see what the eardrum looks like. They can get that from anywhere. So when the urgent care provider says you have an ear infection or you don't have an ear infection, we're not going to prescribe antibiotics. I want you to go see your pediatrician tomorrow. And the pediatrician shows up and sees the converse. They can look at that and say, okay, well, the disease is progressing. The disease is in decline. Or if it carrying it from the pediatrician to the ENT, the guidelines call for 3 ear infections in a 6-month period or 4 and 12 months. Well, some of those are subjective. And if you're a parent taking your kid to a primary care office, you may not see the same provider twice in a row. So now you have what is your ear infection versus what is somebody else. Again, we talk about objective proof. There's no more opinion. There's no more, I don't think so, I do think so. It's very clear so that when they show up for suspected tube placement or, further evaluation at a ENT office, an ENT office, it's very clear. There's no argument. There's no opinion. And having launched other technologies in the plastic surgery space that provided similar objective proof, the quality of care increased for everybody. Everyone's worried about referral patterns, and I don't want to upset my pediatrician. This takes that argument away. It either was or it wasn't. So, even the audiologists, when they make their assessment, utilizing, say, for example, OtoSight instead of a tympanometer, it's very objective. There's no how good was the exam, how good was the technician who did the exam. It's very clear, objective, and the proof is there in the images you see in the medical record.
If I can expand on that, as an otolaryngologist, we're referred patients for a variety of abnormalities, and the indications for tube are multiple, or for tympanostomy tubes are multiple. And so what Jeff was just referring to was the baseline indications for placement of tubes for recurrent ear infections. There's also placement of tubes for persistent middle ear fluid. And the truth is that for many, many, many years, there's been this problem of believability. The patient comes into the office, they've been told by their primary care provider that they've just had their 5th ear infection in 6 months and are on yet another course of antibiotics. And as you go through the evaluation and you evaluate the ears are looking normal. Well, this was problematic for many, many years. And several years ago, our academies, the American Academy of Otolaryngology and our mother organization, American Society of Pediatric Otolaryngology, came out with a guideline saying, in order for the otolaryngologist to be comfortable placing tubes for recurrent otitis media, for ear infections, they should see an abnormal eardrum. And that's this concept of believability. It's not meant to be a pejorative comment about primary care providers. It's meant to be a comment about the challenges of really making an accurate diagnosis in a squirming kid with an otoscope. And so this removes that aspect of things to be able to say, well, here it is. It's the same thing as if we're going to place an ear tube for persistent middle ear fluid. We want to see an audiogram, which is as objective as one could get in terms of assessment of the hearing. If the audiogram is normal, maybe we don't need to place an ear tube quite yet. Maybe we need to wait and watch a little bit longer. And so I think that the OtoSight provides that extra sense of objectivity and, if you will, believability that allows the otolaryngologist to more comfortably say to the parent, I think the time has come to move to the next step in management.
Yeah, and as you're saying it, as I think about my children, right? One of them struggled with ear infections as a child. A little bit of a language delay. If this tool was available at that time, we could have potentially correlated their performance on the OtoSight device with their abilities to acquire language development. Because as the fluid dissipates, then you would see an improvement in their language abilities. And so, I think from a parental standpoint, you could almost, and even from a clinician standpoint, you can go in and say, hey, mom, look, these things are changing. They're changing for the better. So you should now see an improvement in your child's behavior or your child's language development or whatever the case may be. Am I correct?
I think indeed you are. I think that we have seen so many technological advancements throughout the medical world, and of course in the non-medical world with iPhones and the newest and the best. And it's been a long time in coming for the ear examination world to catch up in terms of this technological advancement, to be far more accurate, to be able to show the parent, to be able to discuss the situation and to move forward. As you know, there have been issues with the use of antibiotics for the last 30 years in terms of overuse and misuse and concerns with developing resistance versus the incredible benefits of antibiotics when you're treating an acute ear infection. And so this makes it much easier to have that conversation with the parents when you can show them that this is an ear infection and you can compare it to what is not an ear infection. And so either the for using an antibiotic or the not using an antibiotic is far more easily discussed when you have an objective view of the tympanic membrane and looking at what's going on in the middle ear.
Just a brief story on that. So I have a daughter who is, had recurrent ear infections from 12 years old on. And she just kept getting these things and we're like, are they real? Are they not? And they would look in the ear and ultimately it just became dogma. Like, oh, she has another ear infection. They almost didn't even look in the ear. They just gave her another round of antibiotics. Well, now at 20 years old, I started to work with Photonicare and we came home at Thanksgiving 2 years ago, a year and a half ago, and we looked in the ear and there was no fluid, but yet she had just been diagnosed for her, what it was about her 12th round of antibiotics. Lo and behold, no fluid. She goes back to the ENT and they said, well, maybe it's something else. And she ended up having some nerve damage from cheerleading of kids landing on her. So here's a kid for 8 years that received multiple rounds of antibiotics. And again, through that time, right, you're going to different primary care providers, you're going to a urgent care at a university. Nobody is consistent in the care. But had that objective view been done early on, we would say no fluid, now refer to physical therapy and all these rounds of antibiotics. And to this point, she's for the most part resistant to the most common antibiotics that are on the market.
There's to expand upon this, one of the incredible advantages of this tool is beyond parents and beyond the physician practitioner, but in terms of education of our trainees, because it's hard to learn what is right and wrong in the middle ear. It's hard to differentiate infection from fluid. It's hard to know at what point in the whole process you're coming in. Is it midway in the whole process of infection? Is it resolving? Is it just starting? And this provides the ability to take our trainees, our pediatricians, our general practitioners, the urgent care doctors, the emergency room physicians, and to give them the training that they need to make the right diagnosis. In the ENT world, we have all encountered the patients being urgently added on for yet another ear infection for which they have yet another course of antibiotics. The prescription is still in the parent's pocket, but they were just seen 12 hours ago with an obvious ear infection, and you look at the ear and it's completely normal. And that's problematic. It leads to a lot of misdiagnosis and a lot of mistreatment. And the ability to have this instrument, and even within an urgent care setting or in an emergency department, to make a recording and to discuss it immediately with your colleagues if you're not sure, is yet another way of making sure that a patient's getting the appropriate care that they need.
Yeah, and what's going through my mind as you're speaking, Dr. Pransky, and I really appreciate your comment, is some of my colleagues might be saying, well, you have this OtoSight device, is it replacing the tympanometer, or should they work cohesively together? Can you elaborate on that a little bit?
Yes. So you have to understand exactly what tympanometry does. It's not a diagnostic tool. I can't tell you what the diagnosis is. It's a wonderful tool as an adjuvant or complementary to the evaluation. But what it does is it provides a pressure wave and it tells you whether the eardrum is in a particular position or whether it's not moving appropriately, or perhaps the volume is such that there's a hole in the eardrum, but it doesn't give you a diagnosis. And consequently, when you have something in which you can look at it and objectively say it meets the criteria of X, Y, or Z, then that will pretty much obviate the need for tympanometry. Not completely eliminate it. There will be times when tympanometry will be useful, but as a routine test that needs to be done, well, when you get a look at the ear and you have it recorded and you can memorialize it in the medical record and use it to compare for the future, it provides something beyond tympanometry. Remember that audiometric evaluations are complex and involve a lot of different tools to assess the entire hearing status. Tympanometry is one of those, and that's not the be-all and end-all of assessing the ear.
Yeah, and I appreciate you sharing that comment because, again, a lot of my peers might be thinking it's replacing one or taking, and I really appreciate that comment. Jeff, I'm going to come back to two questions really quick about the product, and then we'll move on to reimbursement and revenue. The two questions are training. Does the person that's using this need to be trained? And if so, do you all provide that?
So yes and yes. We find that a lot of times, I mean, Dr. Pransky can speak to this more directly, but there's very little education done in medical school on how to properly conduct an otoscopy exam. We spend a lot of time just going through the ear anatomy, understanding why you approach the ear the way you do with the OtoSight Middle Ear Scope. Training in all actuality takes, to get someone proficient using the device, getting them trained in about a 10 to 15 minute time frame, which we support electronically through a learning management system, but also on site. And then it really takes about 10 to 15 exams for a user to get to that just normal muscle memory they're used to using with an otoscope. It's not that much radically different, but it is from the point of view is that we're depth dependent. So you have to insert the device a certain depth to be able to get the proper reading within the middle ear space that exists. As far as the ability to use it and learning, very, very simple, just takes time. And again, the challenge is you're breaking a muscle memory or a habit that you're used to using and just approaching it slightly differently.
Yeah. And the second question that I have for you, Jeff, you talked about the data, as did Dr. Pransky, but the data is somehow stored. Is it stored on a cloud? Is it stored on a local computer? Because it has to somehow access, you have to be able to access it in your EMR. Can you talk a little bit about that?
Yeah, so our device stores the data on the device and then can be transferred to your internal or on-premises server for manipulation into the EMR. We do not directly integrate to the EMR. I think as anybody within the world of the medical device industry knows, if you connect it with one hospital, you've connected with one hospital. It's a challenging and expensive prospect. So we find that through Wi-Fi, getting it off the device into the network for users, it works out very, very well. Again, it saves on the device as well. So you can go back either through your servers or through the device itself and pull historical data.
Very cool. I appreciate you sharing that. So last section here, and that is practice revenue. People want to know, how is this going to benefit their bottom line? Can you both talk to us a little bit about that?
Yeah, so I'll take it from a reimbursement perspective, and coming from the past wound care industry, I'm always cautious to say the terms of profit or revenue around making money off of a device. But the reality is our device is reimbursed. You've got a reimbursement code that can be applied for you either unilaterally or bilaterally for reimbursement purposes. We see a very robust reimbursement rate with that. We are a category 3 code, so that means that the user kind of dictates what they want to have for reimbursement. There's not a set code at this point. And then as far as revenue outside of reimbursement, which is, again, a very positive situation for us, when a provider can uniquely offer this technology, it really is a differentiator in a practice. Now, we through our marketing have approached, through reaching out to parents and saying, if your provider had this, would you choose this one versus not? And very clearly, having advanced technology is something that parents want for their children. Every mom wants to do the best they can for their child. This allows them to do that. And I know for myself, if I can go to an office that is treating upset stomachs and issues with Coca-Cola versus one that's saying, hey, here's a diagnostic, we know what the problem is, this is how it's being documented, and this is how to treat it, I'm going to go to the one that's a little bit more advanced. And we find that to be the case here as well. So really differentiating as a higher tech practice. Again, frontline care doesn't get a whole lot of advancement. There's not a lot of money being spent by industry to advance what's going on in the pediatrician's office or the family practice office or the primary care office. So being able to offer a new and differentiated technology, that's really important. Again, that's the entry point for parents into an entire healthcare system. So once they're in your primary care network, of course, you're going to get the whole IDN supported with that. Dr. Pransky, you want to add anything to that?
I'll just make a few comments. First, on a little bit of the more global level. Years ago, when lecturing to the primary care physicians, I would indicate that the otitis marketplace was a $15 billion marketplace in terms of office visits, in terms of cost of medications, the use of antibiotics, missed time from work, and all the aspects of taking care of an ear infection. And when you have proper diagnosis, the ultimate result is reduced costs. Either you're treating a problem appropriately and avoiding problems that come with the treatment, such as giving an antibiotic and having an adverse reaction, or you're treating the problem and getting it taken care of appropriately more rapidly. And in the end, proper diagnosis leads to reduced costs on the healthcare system in general. Secondly, in terms of just the day-to-day environment of families, parents going to their primary care physician, word travels quickly. Parents talk to each other. Mommy groups are all over the place. And as soon as one parent goes in and sees what happens and says, I saw my child's eardrum and now I understand why she didn't sleep last night. It was horrible. You could see one ear was okay and the other ear was bulging and red and inflamed. Now I understand. And that word travels very, very quickly. And for the competitive marketplace within patient care, the idea of being up to date at having the best technology, having a comfort zone with your pediatrician. I mean, parents admire, they love their pediatricians, and they want to know that they're getting the best care possible and the best diagnostic decision-making. And the otoscope, as I've mentioned, is just so much better than working with a handheld otoscope. Regarding the learning of the use of the tool, there is nothing within the field of medicine that doesn't require, from the medical school on up, just as in basketball or football, multiple reps. You got to do it. You got to do it again and again and again. And you get better as you do it again and again and again. So of course there's a learning curve, but fortunately, it's not a steep learning curve. You are used to putting something in the ear, albeit an otoscope. And this is an alternate form of it. And you're using the same approach, but you're using a different technology. And it doesn't take long to get better and better at it. Now, of course, there's steps along the way, but the gains are so much more to be able to take this finding and discuss it with your colleagues, or to take it to a meeting and show this picture of the ear and what happened by virtue of what you saw. That aspect of training and education is so far superior to, well, I looked in the ear and this is what I saw. And no one really knows what you saw. It's just what you're describing. So learning how to use the tool is like anything else, a stethoscope or any other device. You've got to listen to the heart about 10,000 times before you can figure out what that murmur is. Well, looking at an eardrum requires a similar sort of training, but this provides immediate feedback and the ability to sit there and talk to your students about what it is they just saw.
Yeah, I'm glad you shared that, because I think that's important for our viewership to understand that. And thank you both. Last question. So, Jeff, as I'm looking at your website, your product is only available in the United States at this point in time. So can you talk a little bit about any future developments without giving away the secret sauce of Photonicare?
Yeah, so we're definitely globalizing the product as well. We're working with some folks in Japan, distribution group in Japan. They are going through our process there, as well as some other countries. So yes, we continue to work towards globalization. As far as the product itself, we continue to iterate as you would with any technology, whether it be portability, size, function. The technology itself is in eye care right now, and as we grow Photonicare, we'll begin to see it. Is in ear care right now, but we have other tissue sites that we can use this technology with as well, whether it be dental or cardiac or dermal or other. So we have other places that we can go with the technology as well. Right now, we're very focused on the frontline care market with OtoSight Middle Ear Scope, and we know we're going to deliver excellence there. Once that's done, we'll go to the next site.
Yeah. Gentlemen, as we wrap up, any final comments for our viewership?
I'll go first, then Dr. Pransky, you can close it out. But I would just say thank you very much for the opportunity to talk a little about OtoSight, to talk about optical coherence tomography outside of the eye, and in this case, in the ear. And we're very thankful to be able to make people aware of it. I think one thing that I would say in closing is everyone's used to the common technologies they're used to using, and it's easy to just say, I'm going to use my otoscope or whatever that is. But just like when we started out with no phone, and then we had a flip phone, and then we had a BlackBerry, then we got to an Apple, and now, whatever your smartphone of choice is, medicine needs to continue to iterate and get better and introduce technology. And the more we do that, the more objective data we get, and the better quality of care we can deliver as a whole. Again, from my bit part as being part of industry, but Dr. Pransky as a provider, I think, can offer better care as well. Do you want to add anything to that, Dr. Pransky?
I think it's like most things in medicine. It's the next step. We've had this otoscope technology for X number of years, and it's been begging to be improved. And we're finally there. We've got the next step. And the bumps along the way have been ironed out, as with any technology. The difference between an iPhone 5 and an iPhone 13, things get better and better. And like driving a Tesla, the software enhancements can be made. It's just the concept of, quote, prove it to me as the otolaryngologist, or prove it to me as the parent, has now been changed to let me show you why I'm doing what I'm doing. So from my perspective, this has been a long time in coming, and I'm delighted to be able to share my experience and expertise with this, and will anticipate that this will take off like wildfire in all of the medical community involved with hearing, with ears, and with medical management.
Well, gentlemen, we really appreciate you all sharing your insights, your product, your services, and how this can benefit the community. And we look forward to catching up with you guys down the road here a little bit. So again, thank you for coming on, and we'll be in touch soon.